skin or sneezing or otherwise. But yeah,
That's right, the wheezes. And then the strange diseases could be almost anything.
yeah,
Right,
they're primary eosinophilias.
right. Okay, so we talked about the red cells and we talked about the white cells. Now, what about the platelets? We know that the platelets do tons of things, but it's responsible primarily for making clots or a thrombus, correct?
Yes. And you know what's interesting? There are several things interesting about platelets, but they're actually not complete cells. They're actually fragments of cells, and that is because they don't have a nucleus. In the bone marrow, which is where all of our blood cells are made, right? That's the factory, and they're made there and then they're released out into the circulation. There are these very large cells called megakaryocytes. And so they're very large cells with a nucleus, but they break off little fragments and they send them out as the platelets. So we call them cells, but in the strictest definition, they aren't. But what they have the ability to recognize abnormal blood flow, and that can happen because a vessel wall has been disrupted. It can happen because the vessel wall gets so narrow that there's turbulence, and it can also recognize when the blood flow basically stops or gets very slow, and you have stasis, like in varicose veins. If they get so dilated that the blood can't flow, people can get clots in their varicose veins because the platelets will also recognize stasis or lack of flow, and they then initiate clotting.
Okay.
Now, there are soluble proteins in the blood. Remember, we talked about the blood as a salt and protein solution with suspended cells. The platelets initiate clotting, but then they tell the proteins that are in solution in the blood to come and form that clot.
Okay, so what you're outlining is, I think, part of why a simple blood test like a CBC that's ordered thousands of times every day throughout the country, that can be hugely valuable to a clinician and to a patient. We can tell if there's enough circulating red cells, if they're anemic or not, or if they have too many red cells. We can tell something at a glance what's going on with the white cell count, and we can get an idea also about the platelets. So, Dr. Wilson, and I wish we had more time, you have got a lot to teach, but what about what we call the complete metabolic panel? Like oftentimes we will order a CBC and a CMP. So what does that mean? CMP, I know, stands for complete metabolic panel. What does that tell us?
So, just to back up and say, metabolism is the net sum of all the chemical reactions that your body is doing to try to keep us in homeostasis, right? So we consume foods, and we need to break those down into building blocks, absorb those building blocks, and then put them to use for us. Our cells, when they're putting that to use, they produce byproducts that our body wants to get rid of. That whole process, that whole net sum of all those chemical reactions involved in digestion, absorption, distribution, and breaking things down and then putting them back together, that's all metabolism. And really, of course, the intestinal tract does the digestion and absorption. But from there on, it's largely handled by the liver and the kidneys. And the net result is what's in the blood. We need potassium and sodium and calcium and chloride in our blood, but we don't. They need to stay in very narrow limits. Most of that is done by the kidneys. The kidneys, if we need more potassium, they'll hang on to it. If we have excess potassium from our meals, it'll dump it. The kidneys are a big filter. So our blood goes through this filter, urine comes out. If we have a lot of volume of blood, it'll make more urine. If we don't, it'll hang on, and it won't make as much. But it has to be very concentrated because it still has to get rid of those byproducts of metabolism.
Okay, so Dr. Wilson, to teach the public, most people have heard that you can get an MRI of the kidneys, you can get a CAT scan of the kidneys, you can even get an ultrasound of the kidneys, but we could do a blood test or urinalysis, and which tells us a lot of very valuable information, not about the structure of the kidney, but about how it's working. Isn't that correct? By a simple blood test.
Exactly right. I mean, the MRI, the ultrasound, the CT, they tell us about the structure of the kidneys, or any other organ for that matter, but they don't tell us much about the function. The blood test is telling us how are they functioning. For example, one of the things that the kidney needs to do is to get rid of the byproducts of metabolism. One of the byproducts of the metabolism of proteins is a molecule called creatinine. And if the kidney's doing its function, if it's working normally, there will be a small amount of creatinine in the blood, but not an excessive amount. If the kidney's not functioning correctly, then you'll see that amount of creatinine rise. The same with, there are other tests we can do, but that's the most common and the easiest and the most frequent one we do is we look at the serum creatinine and make sure that it's not too high or too low. The other thing is that the kidney typically filters small, non-complex molecules. The big complex molecules like the proteins, it leaves to the liver. We'll let the liver take care of that. So the kidney leaves the proteins in the blood, typically on average. If it's starting to fail in some way, you might find protein in the urine when you shouldn't, too much protein in the urine. So two of the principal ways at looking at the function of the kidney is to look at that blood level of creatinine and how much protein is in the urine. Those two simple things right there give you a ton of information about the kidney function.
So we can gain that information, we can learn that information from a blood test and a urine test, a urine sample,
right,
which can be incredibly valuable. We only have a few seconds left, Dr. Wilson, but just mention briefly about the liver. Part of that complete metabolic panel will be liver function tests, right?
That's
what we
correct.
call LFTs.
That's correct.
So how is it that doing a blood test can tell us how the liver's working?
Well, similar to the kidney is supposed to get rid of that creatinine, right? If it doesn't, it builds up. The liver's the same way. If the liver should be recycling bilirubin, which is a breakdown product of red blood cells. And so the bilirubin shouldn't get too high. If it does, that means the liver's not doing its job. Now, on the other hand, the liver makes albumin, which is probably the most common blood protein. If the liver is doing its synthetic job correctly, there will be adequate albumin in the protein, in the blood. If there isn't, then the liver is not doing its job adequately. And then the other ones are markers of liver cell damage. There's some proteins called transaminases, which are in very high concentration normally in the liver cells because the liver's like a chemical factory, but there's very little in the blood. If we see that level go up, it indicates liver cell damage. So we have cells that tell us about liver function, tests that tell us about liver cell function, and then also tests that tell us about liver cell damage.
Okay, so in summary, when we go to the doctor's office or we go to the emergency room and the doctor wants to order some blood tests, laboratory tests, you've outlined how just getting a little bit of blood sample can provide hugely valuable information about how the kidneys are working, how the liver's working, what's going on in the bloodstream. It's really fascinating. Dr. Wilson, I wish we had more time. During the break, we're going to figure out when we can get you back. And once again, it's a pleasure having you here. It's great that you have so much to teach to the public. That's Dr. Hugh Wilson, board-certified pathologist. And once again, I'm Dr. David Morwood. I am a board-certified plastic surgeon here on the beautiful Central Coast of California. We're going to take a very brief pause for a very good cause.
It's scary making the decision to have reconstructive surgery, but it's so worth what you get out of it.
I'm stress-free. I know I'm not going to get breast cancer.
Everything is back to normal, and it really did not take long to bounce back.
I have a sense of hope for other women that this surgery can help them to live normal lives.
This year, more than 200,000 women in this country will be diagnosed with breast cancer. For many of them, a mastectomy or removal of the affected breast will be recommended as part of the cancer treatment.
The idea of losing a breast for some women can be almost as difficult as being diagnosed with breast cancer. Modern breast reconstruction can help. The purpose of this presentation is to provide women with valuable information about the major issues in breast reconstruction.
We'll have an opportunity to speak with women who chose different methods of reconstruction. We'll talk to experts in the field of breast cancer, and we'll let you know your options for breast reconstruction.
I embraced the mastectomy and reconstruction procedure, and because of that, I had a terrific outcome, and it's changed my life in a positive way.
For the thousands of women who will be diagnosed with breast cancer this year, we understand this is most likely a troubling and frustrating time. We hope this presentation's been valuable to you and will help you make some very difficult decisions that you're facing.
Welcome back to the Doctor is In television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon here in beautiful Monterey, California. Thank you very much for joining us. What I'd like to talk about today in this next segment is how we advise a patient, how we can help someone choose the best procedure or treatment for themselves if they want to look their best. Because as we know, when we look our best, we oftentimes feel our best. It's normal, natural, healthy. It's embedded in our DNA to want to look our best. So there are so many options and choices and alternatives today. You can pick up a magazine. You can read about Botox and fillers and Juvederm and Voluma. You can hear about laser and you can hear about peels. And then, of course, you can hear about facelifts and mini lifts and you can hear about ultrasound. And it gets to be really kind of mind-spinning for many people, almost numbing that there are so many choices, so many alternatives with treatments that can help you to improve your appearance or maintain or help you to look your best. I'd like to start out by defining a few terms for you, which I think will go a long way. Let's say you want to come into our medical spa, Revitalescence, or let's say you want to schedule an appointment to see a plastic surgeon, or you want to see a dermatologist, or you're thinking about laser, and you're trying to sort some of these terms out, and you're trying to figure out what's best for me. Well, let's discuss a few terms. First of all, there's a term called non-invasive treatments. In summary, what is a non-invasive cosmetic treatment or aesthetic treatment or beauty treatment? Essentially, that's a treatment that there's nothing penetrating through the skin. And to be more technical, to be more actually practical, there's nothing penetrating through the epidermis. Now, we've discussed before in other segments that the skin has many layers, but for all intents and purposes, we're going to talk about the epidermis. That's what we see. That's the very superficial layer of the skin, being on top of the dermis. And under that is the subcutaneous fatty layer. Then there's the fascia, that connective tissue that can be very thin and wispy like wet tissue paper, or it can be very thick and heavy like a leather belt. Then we get to the muscular layer. Then we get to the lining over the bone, that's the periosteum. Then we get to the bone itself. So for non-invasive treatments like superficial chemical peels or skincare or facials, what that means is that the treatments do not penetrate deeper than the epidermis itself. Now, many non-invasive treatments can actually have effects in the deeper layers. They can actually improve collagen deposition in the dermis. They can result in more hyaluronic acids. That's a molecule that comprises many fillers these days, that hangs on to moisture, hangs on to water that's in the dermis. So it can actually result in improved collagen and improved hyaluronic acids in the dermis, for example, and stimulate blood flow. But the treatment itself does not go beyond or through the dermis. Now that's key for a number of reasons. First of all, an esthetician, for example, in California is allowed and licensed to do non-invasive treatments. So an esthetician is licensed to be able to administer treatments that do not go or invade below the epidermis. Now, there's another term, what we call minimally invasive treatments, aesthetic treatments or cosmetic treatments or beauty treatments. Many times they're done by a nurse. They can be done by a plastic surgeon. When I say minimally invasive, oftentimes these treatments will obviously affect the dermis or even below the dermis, and they're administered with a needle, for example.